this is continuing from our case series that I presented yesterday. So just a quick recap. Our last video, a 47-year-old busy mom with elevated LDL 186, high blood pressure that was not well controlled, prediabetes, poor sleep, strong family history of heart disease. And for the past 3 years, she's been working on lifestyle changes to manage her cholesterol because she does not want to be on medication. Now, first, an LDL of 186 is concerning, but that is not the whole picture, right? Preventive medicine is much more nuanced than that, especially when we're talking about cholesterol. And one cholesterol number that's high does not automatically equal a statin. Her real risk is what we need to figure out. We need to figure out what her real cardiovascular risk is, and that's a combination of her high blood pressure, insulin resistance, her visceral fat, her sleep, quality of sleep, stress and stress management, being a busy mom, family history, does she have sleep apnea, and is this LDL also worsening because of perimenopause transition? And this is very important with women's health as well, because we all know that with decline of estrogen, you have increasing cardiovascular risk. Estrogen levels change during perimenopause. We often see worsening cholesterol, rising high blood pressure, more visceral fat, unfortunately, and worsening insulin resistance because we have sleep disruption and increased long-term cardiovascular risk. So for her, the next question really becomes, what is her actual cardiovascular risk? Because traditional risk calculators do have limitations, right? The standard ASCVD risk calculator is a great starting point, but it can underestimate risk in younger and middle-aged women. It also does not include taking into account other cardiac labs like her apolipoprotein B, her lipoprotein A, the fact that she's in menopause transition, or other severe metabolic risk enhancers. So sometimes a patient's calculated risk may look deceptively okay on paper, but really, while their long-term risk is much higher than that. So this is where we start thinking about her lifetime cardiovascular risk. We do need advanced lipid markers and laboratory testing to evaluate also her metabolic health, and sometimes a coronary artery calcium score. So just very briefly, a coronary calcium score helps us look for actual calcified plaque in the coronary arteries, keeping in mind that this does not tell us much about soft plaque. Now, this can become a major decision-making tool for some patients, especially those who are hesitant about starting statins or really any other medication for their cholesterol. And they, however, are found to be at an intermediate risk and where treatment decisions are not quite clear. So, for example, if a calcium score is 0, this can suggest lower short-term risk, really taking into account the whole picture for the patient, for family history and her risk factors. But it doesn't mean 0 risk because, like I said, we don't know anything about soft plaque. Now, in younger patients with strong family history of metabolic disease, a 0 score doesn't mean 0 risk. But a calcium score, let's say, of 100, that suggests significant plaque burden and a much higher cardiovascular risk. And that percentile of patients need to really consider aggressive approach at this point. So on my next video, I'm going to talk about what labs do we need to order in this patient, because advanced cardiovascular and metabolic testing is needed to get really the good picture of what her lifetime cardiovascular risk is. So follow along for our next video. We can discuss her laboratory studies that we have not done yet.